Doctor, please stand and raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
Yes, I do.
You may be seated. Please state your name for the record. Spell your first and last names.
Paul F. White, P-A-U-L-W-H-I-T-E.
Dr. White, good afternoon, sir.
Thank you.
You have been present during the testimony of other witnesses and have heard the admonitions to those witnesses?
Yes, I have.
Is that acceptable, sir?
Absolutely.
Thank you. At this time, direct examination, Mr. Flanagan.
Your Honor, could I ask for some water? I'm a little bit
I
tired.
think you're entitled, just as every other witness has been. Do you want the water before you begin?
If I could,
You may.
please.
All right, thank you. One moment, please. Thank you, Deputy Jones. Direct examination, Mr. Flanagan.
Thank you.
You're welcome.
Dr. White, you're basically retired now, aren't you?
Well, if you ask my wife, I don't think she would agree.
You're basically consulting now?
Well, I'm consulting, and I'm also responsible for clinical research projects at institutions in the U.S. and abroad.
Prior to, when did you retire from the active anesthesiology business?
I retired from the University of Texas Southwestern last September.
Okay. Now, prior to your retirement, what was your occupation?
I was a practicing anesthesiologist and conducted a lot of research related to acute and chronic pain management.
What's your educational background to qualify you to practice in this field? Well, let's start with high school. You a local guy?
Graduated from Indio High School.
Where'd you go after Indio?
I went to University of California at Berkeley, or Cal.
Where'd you major in there?
I majored in biochemistry.
And you finished that in 1970?
Yes, in 1970 I graduated from Berkeley.
What'd you do after Berkeley?
For 1 year I worked as a research chemist at Biorad Labs in Richmond, California.
Doing what?
Actually working on an FDA project, developing a project for submittal as an FDA device.
You say you did that for 1 year. What'd you do next?
Actually, I started graduate school at Scripps Institute of Oceanography in San Diego.
And what were you doing there?
I was doing microbial research, biochemical research.
And you say you went there 1 year. Is that a 1 year program?
No, actually, I only attended for about 6 months because I developed a renal problem that led to some extensive medical testing and actually piqued my interest in eventually doing medical research.
So what did you do in pursuit of that?
I applied to graduate school at the University of California, San Francisco, specifically in pharmacology because I had an interest in drug development and studying drugs for the treatment of diseases.
You applied for that. Were you accepted?
Yes, I was.
And did you graduate?
Yes, I completed a PhD in pharmacology at UCSF.
When did you complete your PhD?
Well, I actually, 2 years into the program, I decided that because of my interest in doing clinical research ultimately, that I should apply to medical school. So I actually did a combined program, and I obtained both degrees from UCSF in 1977.
So, and the degrees that you obtained were what?
Well, the PhD in pharmacology and a medical degree.
And after you got your medical degree, that was 1977?
Yes, sir.
Is there an internship required?
Yes.
Where'd you do that?
I was accepted into the internal medicine internship and residency program at UC San Francisco.
And how long a program was that?
Well, I was able, because I was eventually planning to go into anesthesiology, to do what's called fast track. So I was able to save 1 year on my residency because I was doing a second residency, namely anesthesiology.
And the anesthesiology residency, how long a program is that?
Well, at the time I completed the program, it was only 2 years. Now it's 3 years.
And so you completed that when?
In 1980, I think.
After completing your residency in anesthesiology, what'd you next do?
I accepted a faculty position at Stanford University in the
And?
Department of Anesthesiology.
What was that faculty position?
I was the director of ambulatory or outpatient anesthesia and assistant professor of anesthesiology.
And when you accepted that faculty position, had you basically completed your formal education?
Yes, finally.
So that was that, about 14 years of medical school and residency and internship and PhD?
Oh, more like 10 years.
10? Yes, you got your bachelor's degree at 70. You've completed the rest of your medical education by 80. Now,
Yes.
in addition to, once you completed that education, were you licensed in by any agencies?
Well, it was about 2 years later, I first of all took the exams for board certification in internal medicine, and I obtained my medicine boards, and then a year later, I think it was 1981, I obtained my board certification in anesthesiology, so I have dual certification.
So you're now a licensed MD in what states?
In Texas and California.
And you're board certified in what specialties?
In internal medicine and anesthesiology.
Now, what university appointments have you had the opportunity to take during your career?
Well, my initial appointment was as an assistant professor at Stanford University and director of the ambulatory surgery unit. And then in 1988, I was offered the position of professor and vice chairman of the Department of Anesthesiology at Washington University in St. Louis. And following that, in 1992, I was offered the position of professor and holder of an endowed chair of anesthesiology at the University of Texas. And along with that, I was the chairman of the department.
Do you have any hospital affiliations?
At which institution? At Texas?
Anywhere. Are you affiliated with any hospitals?
At the present time?
Yes.
Yes. Currently, I'm affiliated as a visiting scientist at Cedars-Sinai Medical Center in Los Angeles, where I direct research for the Department of Anesthesiology.
Now, I don't want you to be too shy, but in looking at your CV, there's listed about 20, 25 honors that you received. Just tell us a couple that are most significant to you.
Well, I guess the ones that mean the most to me are as one of the founding members of the Society for Ambulatory Anesthesia to receive the Distinguished Service Award. I've also been awarded an honorary fellowship from the Australasian College of Surgeons and Anesthetists, and I've been asked to give various honorary lectureships around the world.
So an honorary fellowship, is that like when you give a speech or a commencement address to give you an honorary degree?
Well, it was more than a commencement address. I actually had to travel to multiple cities in Australia and give many lectures. And they typically honor one individual from North America every 2 years.
And when you're giving these lectures, what's the topic that you lecture on?
Well, the most common topic I'm asked to address relates to pharmacology of newer drugs and techniques for ambulatory or day surgery. But I also frequently address topics related to acute pain management.
You use the term ambulatory surgery. What does that mean?
Well, ambulatory surgery or day surgery commonly refers to procedures where patients are discharged home on the day of surgery, although it often includes what we call short stay surgery, which means patients are hospitalized overnight but are discharged prior to 24 hours.
Well, you indicated that when you went to Stanford that you were a director of ambulatory surgery?
Director of outpatient anesthesia or ambulatory anesthesia. It was a new position because the specialty was in its infancy, I would say.
Well, while you were doing this directorship at Stanford, what was your main interest as it related to anesthesiology?
Well, as the field was expanding, that is, more surgical procedures were being shifted from hospital-based or inpatient to ambulatory procedures, I was focused on developing techniques which would allow patients to recover faster and return home and resume their normal activities of daily living. So my focus was on drugs and techniques that would facilitate that process.
And when you were first starting in ambulatory procedures at Stanford, what was the drugs of choice? What were the drugs of choice?
Well, there were many fewer drugs than we use today. The most common IV anesthetic was thiopental, also known as pentothal, and a shorter-acting barbiturate known as methohexatol or brevital, as well as the commonly used gaseous or volatile anesthetics, halothane and isoflurane, and nitrous oxide.
In your capacity at Stanford, you were looking for new drugs that didn't have these side effects?
Yes, as a clinical pharmacologist, I was familiar with many new innovative drugs, and one of the drugs that I was introduced to by a colleague from Europe, Professor John Dundee, who was considered the father of intravenous anesthesia, was a novel compound known as propofol, which was being studied in the early stages in the United Kingdom and in Belgium.
Now, is this a drug that was being used anywhere?
It was being used in investigational studies in Europe. However, at the time there was a problem because it was water insoluble, so it was solubilized in a cremophore solvent, and the cremophores can be associated with severe allergic reactions. So although the drug was very effective, the allergic reactions led to its withdrawal from the market in England and in Europe.
So what did you do to pursue investigation of this drug?
Well, in chatting with Professor Dundee, he suggested that I contact Imperial Chemical Industries, or ICI, who were working on developing a new formulation of propofol, which involved a lipid emulsion, like intralipid, a white milky emulsion, to solubilize the drug and avoid the allergic complications.
So before developing the white liquid, was it a clear?
Yeah, it was a clear solvent. It had some viscosity, thicker viscosity than water, but yes, it was clear.
Okay, and so how did you go about commencing your investigation of this drug?
Well, I was a very young professor, and although I had some reputation because as part of my residency and graduate school work, I wrote some key papers on ketamine, another anesthetic, and separated the isomers of ketamine, one of which is now commercialized in Europe. But I contacted the company, ICI, in the UK and asked about the possibility of becoming involved in early studies with the new emulsion formulation of propofol when it would be introduced in the US. And they introduced me to Stewart Pharmaceutical in Delaware, which was the company that was going to be responsible for organizing the studies in the US.
So when you pursued this with Stewart Pharmaceutical, what did you do?
Well, I called up the representative. Stewart Pharmaceutical, interestingly, is not an anesthesia company. They actually are most well known for antacids. In particular, Mylanta was their big product. So they weren't terribly familiar with anesthesia, and they were very appreciative of input from anesthesiologists at this stage. And I suggested a study that I thought could have great importance because in the ambulatory setting, as I mentioned, the barbiturates which we used had hangover effects and also high incidence of nausea and vomiting when they were used.
Did they accommodate you in allowing you to study their drug?
Well, I developed a protocol, and it went through review within the company, and they said it sounds interesting. We would support you doing this study, which means they provided a grant for the study, for me to conduct the study, and I obtained Institutional Review Board approval at Stanford and commenced the study in 1993, 94.
What year?
No, I'm sorry, 1983 or 84. I misstated that.
And what was the object of your study? Well, first of all, strike that. They didn't just send you a bucket of propofol. They wanted to know what you're going to do with it first. Is that correct?
Yeah, it's a lengthy process. The protocols are reviewed internally within the company. And of course, I have a lengthy process at my local institution. So it takes several months to, even after the company gives you the go-ahead, to be able to think about
now, when
organizing.
You use the term a protocol. What is a protocol?
It's sort of a template for conducting a clinical study. It describes inclusion, exclusion criteria for patients, the objectives of the study, obviously the detailed methodology that will be used, how the data will be analyzed, and provides a background as to the rationale for conducting the study.
So before they send you any drug or any of the propofol, they want to know exactly what you're going to do with it.
Yeah, they want to read the detailed protocol, correct.
And then they want to know what criteria you're looking for, how you're going to evaluate your criteria, and things of that nature.
Yeah, very detailed methodology is required.
How long did that take you to get that protocol to them?
Well, in those days, things moved quicker than today, so I was able to get that completed in about 6 months.
And did you have any help in developing the protocol, or is this something you did by yourself?
Well, in those days, I was on my own. As a young professor, I didn't have postdocs, fellows, and there were some medical students that would help me out with projects.
So you got to go to your school or your university, get their permission, develop a protocol, send it to them, have them approve it, and then you can start studying it.
Yes, of course, the company has to approve it first, because otherwise I can't obtain the investigational drug.
Okay. Now, once you got past the point where they approved your protocol and were willing to send you the drug, what was the next step?
Well, you organize with your surgical colleagues appropriate patient populations to study. I was fortunately able to recruit 2 excellent Stanford medical students to help me with the project. And we got started pretty quickly.
And
I might add, the study was to compare propofol, this new formulation, to the standard at the time, which was the short-acting barbiturate methohexatol. So it was a direct comparison, and both groups also got nitrous oxide for induction and maintenance of general anesthesia.
So basically, you had done a couple papers before this, but this was one of your early papers. Is that correct?
Well, I had done several papers. As I mentioned, my PhD thesis was based on the IV anesthetic ketamine and its pharmacology in animals and in humans. So I had probably 10 or 15 publications by the time I started my position at Stanford University.
Your interest was basically in IV anesthetics.
Yeah, I started working in the area when I was a grad student and was fascinated by IV anesthesia. And then after meeting Professor Dundee, my interest kind of grew.
Before then, what was normally used for an anesthetic?
Well, the normal anesthetic involves giving an intravenous drug to put patients to sleep. Many patients think, oh, I just got an IV anesthetic. But in the U.S., typically, once you lose consciousness, then the anesthesiologist will turn on a vaporizer and administer what's called a volatile or gaseous anesthetic, along with nitrous oxide, although nowadays nitrous oxide is being used less commonly because of concerns about environmental pollution.
So before you ever actually investigated propofol, you'd published 15 papers?
I would say approximately, yes.
How many papers have you published relating to your field of anesthesiology?
Close to 450 peer-reviewed publications.
What's a peer review publication?
Well, that's where a manuscript is submitted to a journal and it's sent out for review by experts in the field, and then generally there are various modifications that are made, and if you're successful and I guess a bit lucky, it's accepted for publication. And the process takes about a year all total.
So you send out your manuscript, which is your study, study, which usually involves protocol, the actual investigation, the conclusion. You send that out to a journal and ask them to publish it.
Correct.
They evaluate whether they're going to publish it based upon what they perceive as the merits of the study.
Yeah, it's typically reviewed by 3 experts in the field, and you get back their comments. They're generally blinded, but some reviewers reveal their names. So.
Now, you've actually had 435 published?
Well, there's a few others that are in lesser journals that I don't list. But yes, that's the number of publications on called PubMed, which is a common reference source.
Okay, after doing the first 15 and you started on propofol, did you have a series of studies that were published concerning propofol?
Yeah, after completing the initial study, which demonstrated that using propofol instead of the barbiturate allowed patients to not only awaken quicker but ambulate sooner, and they had 50% less postoperative nausea and vomiting. And it was very exciting. I mean, there was a press conference with a local TV station and tremendous interest in the potential of this drug for day surgery. And after that, I went back to the company and asked them if I could perform a follow-up study in patients having major surgery where we would focus on trying to understand the pharmacokinetics and dynamics of the drug so we could use it better during surgery. As you pointed out earlier, that it was not usual to use an IV anesthetic for induction and maintenance of anesthesia in the U.S. So we needed to kind of define the parameters of dose and response.
Now, at the time that you're doing this, propofol's not even FDA approved, is it?
Oh, no. This is 1986, and it was approved in 1989 for use in general anesthesia.
So you had spent 6, 7 years researching propofol before you could finally even get it approved for use in the United States?
Well, I don't get it approved. The FDA does the approving, and the company submits it. But I started working with propofol in 1983, and it was approved 6 years later in 1996. In 1986, I apologize.
Since you started studying this and writing papers on Your Honor, I have an exhibit I'd like to mark as, and it's next.
Triple X. Triple X.
Referring to Triple X, Dr. Schaefer, is this an itemization of 36 studies that you've done that deal with propofol?
I'm Dr. White.
I mean, Dr.
but
White, excuse me.
Dr. White, Dr. Schaefer's a good friend, and he actually helped me on one of the papers.
I'm showing you Exhibit Triple X. That involves page one. Your Honor, it's a 6-page document. The first 3 pages constitute an itemization of 36 studies done by Dr. White involving propofol only. Is that correct, Doctor?
Yes, it is. And the study I was referring to actually as the first study, which was conducted in the U.S., was the comparison of propofol with methotrexate. That's published in 1986.
That's number 4.
That's number 4, yes, sir.
Now, you published in 86. When did you start the study?
The study was started in about 1983.
So it's a 3-year study. Now, I noticed that...
No, the study was completed within 6 to 8 months. But it requires time to analyze the results, to prepare the manuscript, and to go through the review process, and then the publication delays. So that's not unusual.
Now, I noticed that your name is the 3rd name up there. There's Doe's, looks like Westphal, and White. Was this Doe's study, or was it your study?
Well, Van Does and Westphal were both medical students at Stanford, so it was my study, and I conducted the anesthesia.
How come your name appears last?
Because frequently as a senior author or principal investigator, you'll put your name in either the last position or the 3rd position if there are many more authors.
I noticed there's a lot of studies up there. Your name is in the... I guess those are when you're the only one on the study. Looking at number 9, I see the name Schaefer, A. Was that another study done by you?
Yes, it is.
Who was the principal investigator on that?
Well, I designed the study, organized the study, and Dr. Audrey Schaefer was my second fellow. So she had actually just completed medical school. She had not had any postgraduate training in anesthesia, but she had completed her medical education. And Van Does, again, was a medical student. And then Stephen Schaefer, who was also a medical student at the time, helped out with aspects of the data analysis and modeling.
And you set up the parameters for the study?
Yes.
Now, both Schaefers, they were Mr. or Dr. and Dr. Schaefer?
Yes, they
were
married.
When did you meet them?
I met the Schaefers probably in 1981, shortly after I arrived at Stanford. They came by to talk to me about doing research in anesthesia.
In addition to these studies that you've published, have you done any research investigation regarding benzodiazepines?
Yes, I actually did one of the first studies with midazolam when it was introduced for sedation during local anesthesia with some plastic surgery colleagues, and a study involving using midazolam for induction of anesthesia in the mid-1970s. Midazolam is also known as Versed. It remains a very popular sedative.
I note that there's 18 studies listed under the relevant clinical studies involving benzodiazepines. Is that 18 studies that you've done involving benzodiazepines?
Well, that's probably an approximation. I'm not saying they all were totally focused on benzodiazepines, but benzodiazepines were a part of the study. Many of them were studies specifically targeting the use of benzodiazepines in the operating room and also in the intensive care unit for sedation.
During your career, how many books have you read or written?
Probably
Well,
written.
Excuse me.
Written.
Why don't you re-ask?
During your career as an anesthesiologist, subsequent to your graduation or completion of internship, have you written some books?
I think I've written approximately 15 books, 2 of which are major textbooks for the specialty, one on ambulatory anesthesia and surgery, or 2 actually on that topic, and 1 on intravenous anesthesia.
This triple X, you've itemized 5 textbooks. Are those ones relating to propofol?
Yes, not only propofol, but actually drug manuals, which talk about all the drugs that we use in the perioperative period, which means the time around surgery.
And in addition to writing books, are there chapters that you've written for books?
Yeah, I've written chapters on intravenous anesthesia and ambulatory anesthesia and surgery for most of the major textbooks in the specialty,
And
including my own.
you've written 21 separate chapters?
It's actually 88.
Well, I'm talking about just relating to propofol.
Yes, that's probably a good approximation.
Now, Doctor, how were you contacted in this case?
Well, I think it was in January of this year, actually. I got a phone call sort of from you just out of the blue. I was working from my home office, and you called and introduced yourself and mentioned the name Conrad Murray.
Was that name familiar to you?
Yes, I had heard the name, and I think I paused and was quiet for a minute.
Okay, and when I mentioned that name and mentioned the case involving the death of Michael Jackson,
Yes, you did.
what were your thoughts?
Well, my thoughts were I really wasn't sure that I wanted to get involved in a high-profile celebrity case involving the death of an icon.
Why not?
I'm just not a public person, and I really don't enjoy all the attention.
Was it my persistence that caused you to look further in this case, or was it some other reason?
Well, in honesty, my wife said I shouldn't say no so quickly, and I think what I suggested to you was, could you send me some materials? When I first heard about the case, I had heard suggestions as to what the causes were, and because I'm very familiar with these drugs, especially propofol and opioids, narcotic drugs were mentioned, I said I agreed to review materials for you. I think it was in early February, and upon review, I would let you know whether I was willing to become involved as part of the defense.
Now, this deal immediately with the elephant in the room here.
Elephant in the room. Okay.
The elephant in the room being Conrad Murray has been accused of infusing a dose of propofol and leaving this patient. Can you justify that?
Absolutely not.
Well, after I sent you the papers, did you automatically agree then? What did I send you? Do you recall what you had at that time?
Again, I may miss some items, but you sent me Dr. Murray's interview with the LAPD. You sent me the coroner report, toxicology, a plethora of expert documents.
13 expert opinions prior to Dr. Schaefer's?
It was a pretty thick packet. And I think that was all that I recall at the moment.
Did I send you some court testimony from witnesses that appeared at the preliminary hearing?
Yes, I believe you did.
Was
Correct.
that Dr. Ruffalo, Dr. Rogers?
Yes, it was.
Now, I take it you ended up reading all of that?
Yes, I read all these documents, and I was somewhat perplexed as to how the determination had been made by essentially all of the experts that Dr. Murray was infusing propofol, because in my examination of the documents and the evidence that was described, it wasn't obvious to me. And I thought that there were questions if, in fact, Murray had administered the drugs that he described in his conversations with the police department and the doses that he described. I would not have expected Michael Jackson to have died.
So did you, as a result of reviewing these documents, did you automatically say, yeah, I'm on board?
No, I did not. I actually...
What was your next request?
Well, I think I told you that I would like to meet face-to-face with Dr. Murray, and that
The objection is overruled. The answer remains.
I asked for
That's
the...
all right. That's the answer. The recent partial answer is stricken.
Okay.
Mr. Flanagan, pursuant to discussions.
When you requested, when you said you'd like to meet with Dr. Murray, did you ever have that meeting?
The objection is sustained. 350, 352. Thank you.
Well, prior to making your decision to...
May we approach, Your Honor?
You may. Give us a moment. Dr. Schaefer, Dr. White, we've had everybody
Do we
asking
look
for
the same?
water. Not at all, and I'm sorry, too.
It's all right.
Dr. White, did you want some more water?
I did.
Thank you, sir. Give us a moment.
I can proceed, I just get a little dry
we'll
when
wait
I'm
a moment.
talking.
I think that's Deputy Jones, and I think I can identify you. I apologize. Dr. White has the water. Mr. Flanagan.